Hello, my name is Joann Wrobel, and during this presentation, I will investigate natural therapies for depression. According to the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, mental disorders are defined as clinically significant behavioral or psychological syndrome or pattern that occurs in an individual. This syndrome is associated with present distress, disability, or significantly increased risk of suffering death, pain, disability, or important loss of freedom. The DSM-5 also notes that there is a lack of consistent operational definitions that cover all situations. Mental disorders cover a wide range of disease states, including anxiety, attention deficit hyperactivity disorder, autism spectrum disorder, bipolar disorder, borderline personality disorder, depression, disruptive mood dysregulation disorder, eating disorders, obsessive compulsive disorder, post-traumatic stress disorder, and schizophrenia. Serious mental illness can cost approximately $193.2 billion in lost earnings each year. According to the National Institute of Mental Health, nearly 1 in 5 U.S. adults has a mental illness, or 46.6 million Americans. As projected in the graph, mental illness is more prevalent among women than men, and most prevalent in young adults aged 18 to 25 years. The highest prevalence of mental illness is found among adults who report 2 or more races. Mental disorders are not limited to a specific population set. However, there are health disparities within diverse populations. Racial, ethnic, gender, and sexual minorities tend to have poor mental health outcomes due to inaccessibility to quality mental health care services, cultural stigma, discrimination, or lack of awareness about mental health. According to the Office of Disease Prevention and Health Promotion, the determinants of mental health disorder include, but are not limited to, the following: race and ethnicity, gender, age, income level, education level, sexual orientation, geographic location, and social conditions such as interpersonal, family, and community dynamics, housing quality, social support, and employment opportunities, and work and social conditions. For the remainder of the presentation, we will focus on depression, or otherwise known as major depressive disorder. Depression is characterized as a mood disorder. The DSM-5 diagnostic criterion for depression dictates that an individual must experience a depressed mood or loss of interest or pleasure in daily activities and has had a majority of specified symptoms, such as problems with sleep, eating, energy, concentration, or self-worth during a period of at least 2 weeks. Currently, depression is treated with either medications, psychotherapy, or a combination of the 2 treatments. Approximately 17.3 million adults in the United States have experienced at least one major depressive episode, or roughly 7.1% of all U.S. adults. As projected in the graph, depression is more prevalent among females than males. It's more prevalent among individuals aged 18 to 25 years, and more prevalent among adults reporting 2 or more races. It is important to note that depression does not only affect adults, but also children. An estimated 3.2 million adolescents between the ages of 12 to 17 have experienced at least one major depressive episode, or roughly 13.3% of all adolescents. The determinants of depression are essentially the same as mental illness. The economic burden of individuals with depression is estimated at $210.5 billion. The combination of direct cost, suicide-related cost, and workplace costs were factored into this estimate. In addition to economic costs, there is also a societal cost of depression, which includes but is not limited to termination of continuing education, marital stability, and employment status. Even though depression has been well studied over the last century, the pathophysiology of depression still remains elusive. There are various proposed theories on how depression works, which include but are not limited to the neural circuitry theory, stress response circuits, genetic vulnerability and environmental interaction, hormonal imbalance, and the biogenic monoamine theory. For the purpose of this presentation, we will concentrate on the biogenic monoamine theory, as the natural therapies to be introduced have been hypothesized to work within this theory. The biogenic monoamine theory suggests that depression is the result of depleted levels of serotonin, norepinephrine, and/or dopamine within the central nervous system. This theory is based on the mechanism of action of antidepressants. The following clip will illustrate the pathophysiology of depression in relation to this theory.
Depression is one of the most common psychiatric disorders. Symptoms of depression are often subtle and unrecognized by both patients and physicians. The brain contains a network of interconnected nerve cells called neurons. The junction between the neurons is called the synaptic junction. The transmission of impulses from one neuron to another is facilitated by chemicals called neurotransmitters. The impulse triggers the release of neurotransmitters from one neuron, which cross the synaptic junction and attach themselves to the receptors in the adjacent neuron, sending the message through. Later, the neurotransmitter returns to the initial neuron via the reuptake channel. One of the causes of depression is believed to be the depletion of the amine neurotransmitters serotonin and norepinephrine. Antidepressant drugs increase the availability of neurotransmitters at the synaptic junction by blocking the reuptake channel.
The first natural therapy for depression that I will discuss is the use of St. John's wort. St. John's wort, or Hypericum performatum, is a leafy herb that grows in the wild. It has been used since ancient Greece to treat both internal and external ailments. Documented uses of St. John's wort in treatment include anxiety, depression, cuts, burns, cancer, inflammation-related disorders, and bacterial and viral disease. It is theorized that St. John's wort, similar to many antidepressants, inhibits synaptosomal uptake of serotonin, dopamine, and norepinephrine. The first study I will present was a randomized, double-blind, double-dummy, reference-controlled, multi-center, non-inferiority trial. It took place throughout 21 psychiatric primary care practices in Germany and recruited 251 adult outpatients with acute major depression. Participants in the study either took 900 milligrams of Hypericum extract WS550 or St. John's wort 3 times a day for the control, 20 milligrams of paroxetine, a commonly prescribed antidepressant, once a day over the course of 6 weeks. For participants who do not respond initially, the dose was increased to 800 milligrams a day of Hypericum or 40 milligrams a day of paroxetine after 2 weeks. The outcomes measured were changes in score on the Hamilton Depression Rating Scale, or HAM-D. In the St. John's wort group, the HAM-D decreased by a mean of 14.4 points. Incidence of adverse events was 0.035 per day. In the paroxetine group, the HAM-D decreased by a mean of 11.4 points. Incidence of adverse events was 0.06 per day. In conclusion, the study found that for the treatment of moderate to severe major depression, St. John's wort is at least as effective as paroxetine and is better tolerated. The limitations in this study included inability to include a placebo control, small sample size, and short study duration. The main effects reported were mild gastrointestinal disturbances followed by a nervous system disorder. The second study was a double-blind, randomized, placebo-controlled, multi-center clinical trial. It took place in 16 medical centers throughout Germany and recruited 332 adult outpatients with an episode of mild or moderate major depressive episode or acute major depression. Participants in the study either took 600 milligrams a day or 1,200 milligrams a day of hypericum extract WS5570 a day, or placebo over the course of 6 weeks. The outcomes measured, similar to the last study, were changes in the HAM-D score. In the St. John's wort group, the HAM-D decreased by a mean of 11.6 points for 600 milligrams a day and 10.8 points for 1,200 milligrams a day. In the placebo-controlled group, the HAM-D decreased by a mean of 6.0 points. In conclusion, the study found for the treatment of mild to moderate depression, St. John's wort at doses of 600 milligrams a day or 1,200 milligrams a day were found to be safe and more effective than the placebo. There was no additional benefit from a higher dose of St. John's wort. A limitation of the study was the short duration and small sample size. The main side effect reported were mild gastrointestinal disturbances, menstrual complications, and photosensitivity reactions. Adverse events occurred at low frequency. The third study was a randomized, double-blind, placebo-controlled clinical trial. It took place in 11 academic medical centers throughout the United States and recruited 200 adult outpatients diagnosed with having major depression. Participants in the study either took 900 milligrams of St. John's wort or the placebo control over the course of 8 weeks. If there was an absence of adequate response after 4 weeks, the dose was increased to 1,200 milligrams a day of St. John's wort. The outcomes measured, as in the previous studies, were based on the HAM-D scale. In the St. John's wort group, the HAM-D decreased by a mean of 14.4 points. In the placebo control group, the HAM-D decreased by a mean of 14.9 points. Additionally, higher remission of depression was found in St. John's wort group versus the placebo. In conclusion, the study found that for the treatment of major depression, the use of St. John's wort was not effective. In conclusion, while a good number of studies have been performed on St. John's wort, a majority of them are of poor quality. They lack a sufficient number of participants and ample duration time. In addition, St. John's wort isn't consistently effective for the treatment of depression. While studies 1 and 2 showed positive results for the use of St. John's wort in depression, study 3 yielded no benefit. Also, there is not a suitable dosage suggested for the general population. While reported side effects of St. John's wort are minor and uncommon, such as upset stomach, dry mouth, or headache, a potential danger of using St. John's wort is its known ability to limit the effectiveness of other prescribed medications, such as birth control, cyclosporine, oxycodone, some cancer medications, and warfarin. Combining St. John's wort with antidepressants can lead to potentially life-threatening increase in the body's level of serotonin, which could result in death. The second natural therapy for depression that I will discuss is the use of curcumin. Curcumin is a chemical found in turmeric that gives the spice its yellow coloring. Curcumin has both medicinal and culinary uses. There is documented medicinal use of curcumin back 9000 BC. Curcumin has been used to treat a wide variety of diseases and conditions, including those of the skin, pulmonary, gastrointestinal symptoms, aches, pains, wounds, sprains, and liver disorders. It is theorized that curcumin inhibits the monoamine oxidase enzyme and modulates the release of serotonin and dopamine. The first study on the effectiveness of curcumin for depression was a randomized, double-blind, placebo-controlled study. It took place in Western Australia and recruited 56 adult outpatients with major depressive disorder. Participants in the study took either 500 milligrams twice a day of curcumin or a placebo control for 8 weeks. The outcomes measured were change in score on the Inventory of Depressive Symptomology Self-Rated Version, or IDS-SR30. In conclusion, the study found that during weeks 4 to 8, the curcumin was more effective than the placebo in improving mood-related symptoms as indicated on the IDS-SR30. The limitations of the study were small sample size, short study duration, and lack of varying dose. The main side effects reported were stomach bloating and pain. The second study was a randomized, double-blind, placebo-controlled study. It also took place in Western Australia and recruited 123 adult outpatients with major depressive disorder. Participants in the study were allocated to one of 4 treatment conditions: low-dose curcumin extract at 250 milligrams twice a day, high-dose curcumin extract at 500 milligrams twice a day, combined low-dose curcumin extract plus saffron at 12 milligrams twice a day, or a placebo for the duration of 12 weeks. The outcomes measured were change in score on the Inventory of Depressive Symptomology Self-Rated Version, or the IDS-SR30. In conclusion, the study found great improvement on depressive symptoms compared to the placebo, but no difference between different doses of the curcumin or curcumin-saffron combination. It is important to note that the difference did not reach statistical significance. The limitations of the study were small sample size, short study duration, 50% of the participants also receiving antidepressant medication, and 15% receiving psychological therapy. The main side effects reported were diarrhea and loose bowels. The third study was a randomized, double-blind crossover trial. It took place in Iran and recruited 30 obese adults. The only criteria for inclusion was the participant had to be obese and have less than 2 risk factors of coronary heart disease. Participants in the study were either given 1 gram a day of curcumin or a placebo controlled for 30 days. The outcomes measured were changes in score on the Beck Anxiety Inventory, BAI, and the Beck Depression Inventory, BDI scales. In conclusion, the study found that there was a significant reduction in anxiety, but no significant change for depression. The limitations of the study were small sample size, short study duration, focus on only obese individuals, and lack of depression diagnosis prior to trial. There were no side effects reported in the study. In conclusion, there are very few studies on curcumin, and of those, they are mostly of poor quality. Similar to the studies on St. John's wort, they lack sufficient number of participants and ample duration time. Also, there is not a suitable dosage suggested for the general population. In regards to safety, the reported side effects of curcumin are minor. However, there are potential drug interactions with turmeric supplementation. These include blood-thinning medication, drugs that reduce stomach acid, and drugs for diabetes. Depression is a serious mental illness, and if left untreated, could become severe and possibly lead to death. Until good quality, large-scale, long-duration studies on the use of St. John's wort or curcumin for depression are conducted, my recommendation would be to hold off on usage. Effective doses for both therapies are unknown, and standardization of the products over the counter are unregulated. My recommendation for those struggling with depression would be to consult one's primary care provider and discuss conventional treatments for depression, such as antidepressant medications and psychotherapy, before trying natural therapies. However, if one is adamant to try either St. John's wort or curcumin, I would recommend informing one's primary care provider about its use and not taking the supplement alongside other medications. The National Center for Complementary and Integrative Health provides general information on the use of S-adenosyl L-methylonine, or SAMe, and relaxation techniques for depression. SAMe is a chemical found naturally in the body. It has been investigated for depression, osteoarthritis, and liver disease. Evidence from studies have suggested beneficial effects on the use of SAMe for depression, but similar to the 2 therapies presented, there are a lack of good quality research to back the claim. Another therapy proposed for depression is relaxation techniques. These include autogenic training, biofeedback-assisted relaxation, deep breathing, guided imagery, and self-hypnosis. Currently, there are only a few studies on the use of relaxation techniques for depression, but of those published, there states that they are better than getting no treatment, however, not as effective as traditional cognitive behavioral therapy.